Let's talk about the Autism Spectrum Disorder, a topic that shows up on your F&P boards and in your daily practice. ASD is a neurodevelopmental condition that is characterized by challenges in social communication and restricted repetitive behaviors. Let's break down what you need to know to ace your boards and care for these patients with confidence. This neurodevelopmental condition is defined by two core domains. The first one is a deficit in social communication and social interaction. And the second one is restricted repetitive patterns of behavior, interest, or activities. These symptoms must be present in the early developmental period, though they may not fully manifest until social demands exceed capacity. It's a spectrum. Presentations vary widely in severity and support needs. Now, according to the CDC, ASD affects approximately 1 in 36 children in the United States. It is about 4 times more common in males than in females, though females may be underdiagnosed due to better social masking. ASD occurs across all racial, ethnic, and socioeconomic groups. The rising prevalence reflects improved screening and broader diagnostic criteria, not necessarily a true increase in incidence. As with a lot of things in medicine, early identification is everything. Watch for things like no eye contact, no babbling by 12 months, no pointing or gesturing by 12 months, no single words by 16 months, no two-word phrases by 24 months, and any loss of previously acquired language or social skills at any age. That last one, regression, is a major red flag that warrants immediate referral. Do not wait and see. The DSM-5 requires deficits in both domains for diagnosis. Domain A covers social communication. Deficits in social-emotional reciprocity, nonverbal communication, and developing or maintaining relationships. Domain B covers restricted repetitive behaviors, and you need at least 2 of the 4. Either stereotype movements or speech, insistence on sameness, highly restricted interests, or hyper or hyporeactivity to sensory input. The severity is rated by level of support needed, either a level 1, a level 2, or a level 3. Earlier intervention leads to dramatically better outcomes. The brain is most plastic in the first 3 years of life. If you have concerns, refer immediately. Do not wait for a formal diagnosis to begin services. Children can receive early intervention services through their state's Part C program under IDEA from birth to age 3. After age 3, services transition to the school system under Part B. Your referral can change the trajectory of a child's life. Now, the treatment for ASD is very individualized and goal-directed. The 5 core treatment goals are improving social skills and peer interaction, enhancing communication, both verbal and nonverbal, building adaptive daily living skills like dressing and self-care, reducing maladaptive behaviors such as aggression or self-injury, and maximizing academic and cognitive function. Treatment plans should be tailored to the child's strengths, challenges, and family priorities. Now, there's something called applied behavior analysis, ABA, and this is the gold standard and most evidence-based intervention for ASD. It uses reinforcement strategies to teach skills and reduce challenging behaviors. Speech-language therapy addresses communication deficits, including augmentative, and alternative communication for nonverbal children, such as PECS, which is the Picture Exchange Communication System. Occupational therapy targets sensory processing, fine motor skills, and daily living activities. Intensive early behavior intervention, about 25 to 40 hours per week, produces the best outcomes. It is important to note that there are no medications that treats the core features of ASD. Medications target comorbid symptoms only. Risperidone and aripiprazole are the only FDA-approved medications for ASD, specifically for irritability, aggression, and self-injurious behavior in children aged 5 and older. Stimulants address comorbid ADHD symptoms. SSRIs may help with anxiety and repetitive behaviors. Melatonin is commonly used for sleep disturbances, which affects about 80% of children with ASD. Always start low and go slow with any medication in this population. ASD management requires a multidisciplinary team. As the F&P, you are the quarterback, coordinating care across a specialist. The core team typically includes a developmental pediatrician or a child psychiatrist for diagnosis and medication management, a speech-language pathologist, an occupational therapist, a psychologist or ABA therapist, and a social worker. The school team is also critical. Genetics referral is recommended for all children with ASD to evaluate for underlying conditions, such as Fragile X or Rett syndrome. Comorbidities are the rule, not the exception in ASD. ADHD co-occurs in 30 to 50% of cases. Anxiety disorders affect approximately 40%. Depression is common in higher functioning individuals. Epilepsy affects about 20 to 30%. EEG is indicated if there is any concern for seizures. GI problems like constipation, reflux, and feeding issues affect about 70% and can worsen behavioral symptoms. Always screen for and address comorbidities at every visit. The AAP recommends universal ASD screening at the 18 and 24-month well-child visits, using the MCHAT-RF, which is the modified checklist for autism in toddlers, revised with follow-up. A positive screen warrants immediate referral for comprehensive evaluation. Do not tell families to wait and see. Early referral is your most powerful intervention. You also play a key role in coordinating the multidisciplinary team, supporting families through the diagnostic process, and monitoring for comorbidities at every visit. You are the constant in the child's care. Seeing a child with ASD in your office requires some preparation. Create a sensory-friendly environment, a quiet waiting area, dimmed lights, and minimal noise. Always warn the child before any physical contact. Use simple concrete language and visual supports when possible. Allow the child to bring a comfort object. Keep the visit predictable. Tell them what will happen before it happens. Consider scheduling the first appointment of the day to minimize wait times. Let's talk about safety counseling, because this is a critical part of every ASD well-child visit. Elopement or wandering affects nearly half of children with ASD, and it is extremely dangerous. Drowning is the leading cause of death in children with ASD, often related to elopement near water. Counsel families to install door alarms, window locks, and pool fencing. Recommend a medical ID bracelet with the child's name, diagnosis, and emergency contact. Encourage families to register with local police and fire departments. These conversations save lives. Let's recap the key points. ASD is defined by social communication deficits and restricted repetitive behaviors. Screen at 18 and 24 months with the MCHAT. Refer early, don't wait. ABA therapy is first line. No medication treats core ASD. Risperidone and aripiprazole are FDA-approved for irritability only. Watch for comorbidities: ADHD, anxiety, epilepsy. And always consult on safety. Elopement and drowning are the top risks. For more high-yield F&P board content like this, visit the fmpreview.com.